Well, my name is Karl Golnik. I'm a neuro-ophthalmologist. I'll explain briefly what that is in a moment in case you don't know. Many doctors don't really know what I do as a neuro-ophthalmologist. I've been asked to sort of talk about acromegaly and vision, and really, it's not, I'd say, not really specific to acromegaly because it's more specific to any sort of a pituitary tumor as far as the vision goes, and I think you'll see why as we run through the presentation. So let me see if I can advance the slide. So the outline is I'm going to briefly tell you what is a neuro-ophthalmologist and then what I do, and then a brief review of the visual system, the anatomy, because I think to understand how pituitary tumors affect vision, you need to know a little bit about the anatomy, and then how do we evaluate that visual system, and then what are the problems that can occur. So what is a neuro-ophthalmologist? Well, basically, you have to go to college for 4 years, you go to medical school for 4 years, then you do either an ophthalmology residency training, which is what I did, or you can also do a neurology residency training and then decide either way that you want to be a neuro-ophthalmologist. And then if you do decide that during your training in residency, you then do an extra year of neuro-ophthalmology. And then, of course, the most important part really is then, for me at least, the next 35 years of experience, which is really how you become an expert. I think most graduates think they're experts in year one, and it's not true. So the 35 years of experience counts for quite a lot. What I do, and this is what I tell doctors when they ask, what do you do exactly as a neuro-ophthalmologist? And I tell them I deal with vision problems that don't affect the eyes. So I often tell people we don't see with our eyes, we see with our brain. And so I don't do things like cataracts and dry eyes and glasses, which often surprise. Wait a minute, you're an eye doctor, you don't do glasses? And I've had patients in my waiting room with my diplomas, and they go, oh, I see you went to medical school. I thought you were an eye doctor. I said, yeah, well, MD ophthalmologists have to go to medical school and do all the rest of that training. So I deal with lots of things: pituitary tumors, other types of brain tumors, multiple sclerosis, strokes, all of the things that can affect the brain can affect your vision, because a lot of your brain, in fact, about at least half, has to do with seeing and processing visual information. So that's what I do. And I love it. If I could go back and start over again, I would do the same exact thing. I wouldn't change any of the things that I've been doing for my entire career. So common conditions: optic nerve problems. So the optic nerve is the nerve that connects the eyeball to the brain. Double vision, because there are all sorts of nerves that control the muscles that move the eyes. I'll show you a video later on and talk to you about how pituitary tumors can sometimes cause double vision. Droopy eyelids. So there are nerves that go from your brain forward that go to the muscles in the lids that keep your eyelids open. And I see a lot of people with unexplained vision loss. So it's kind of, when I was a medical student, I thought it was very interesting and very detective-like. And I'll often see people who've seen 5 doctors. We don't know what's going on. You better see a neuro-ophthalmologist. And then we sort of sort things out. One of my lectures on unexplained vision loss is called House Without the Attitude. Detecting difficult diagnoses. So it's very detective-like, which I thought was pretty cool back when I was a medical student. So those are the sorts of things I see and do. But certainly, I diagnose pituitary tumors frequently because the visual problems outweigh other symptoms in those patients, and they get to me first. So a brief review of the visual system, and this, I have a few slides and then plenty of time to discuss whatever you guys want to discuss. I was told it should be a lot of discussion, but I think to really understand how pituitary tumors affect vision, you need to know a little bit about the anatomy. So please feel free to ask questions if I am not being clear about what I'm trying to describe. So here are the eyeballs. Here's the optic nerve that I just mentioned. And each of these nerves, one on each side, is made of about 1 million little fibers. And those fibers are very topographical. So if you're missing fibers here, then your vision is going to be bad in the same area that corresponds to that. If you're missing fibers here, same sort of a thing. The signal comes back down your nerve. And right here, as I tell patients, right here, if you could connect my fingers, the 2 nerves come together. And where they come together, the optic chiasm. Has everyone heard that? Okay, these guys are all savvy pituitary people. So right at the optic chiasm, half of the information, right down the middle, swaps. So if I took a laser and I lasered any part of the visual system beyond the optic chiasm, beyond it, I would create, if I took a laser spot right here on the right side, I would create a blind spot in both eyes to the other side. So that's the way the visual system is. So it's like your arm getting weak if you have a problem on the right. So a laser to the visual system on the right causes a spot of blind spot in the peripheral vision to the left in both eyes. And that often surprises patients. Well, wait a minute, I thought it was my left eye because it's the right side of my brain, but it's both eyes to the opposite side. And so that those fibers come back here and then ultimately all the way back to the occipital lobe, which is the very back of the head. And that's sort of where vision lives. That's the part of your brain that actually sees. This is all just communication pathways to get there. And the pituitary gland lives right underneath. So we're looking down on top. The pituitary gland lives right underneath. And this schematic, which is, don't worry about all the words in there, but here's the pituitary gland. And now we're looking at the patient or the person straight ahead. And this is a slice right like this, right through the chiasm. So here's the chiasm, here's the pituitary. And that's of course why if that pituitary gets even a little bit bigger, it's going to usually grow upward because there's bone and other things on the sides, but usually upward and pushes on the chiasm. And that affects the transmission of that visual signal back to your brain. That makes sense. Any questions about that basic anatomy? You already know that? Good. Okay. Now, the other thing to mention, although it's not as common as loss of vision, is that on each side of the pituitary, see all these are all nerves, the third nerve, the fourth nerve, the fifth nerve, and the sixth nerve. So these nerves are all right close by. And most of these nerves go to the muscles that move your eye. And so if the tumor happens to grow outward instead of upward, it can cause the muscles of your eyes not to move normally by affecting those nerves. And that can cause double vision, which we'll talk about when we get to towards the end. I'll show you a video of someone with a problem with one or more of those nerves. So loss of vision, most common. Double vision, second most common. Any questions about that basic anatomy? We're good. Okay. So how do we evaluate the vision system? Well, of course, we're going to check your visual acuity. Has everyone has had an eye exam? Yes. Does anyone have vision problems from a pituitary tumor in the audience? Oh, used to. Good. Well, that's good. Used to is the key word there. Okay. So visual acuity can be affected. So if the tumor is big and it's affecting more than just the chiasm, then it can affect either nerve. Because if you look back at that anatomy, sorry, let me go backwards. If you look back at the anatomy, remember the pituitary gland is right under here. But if it happens to grow a little bit this way, or both, it can affect both of your nerves. And so now you're going to have loss of central vision, not just peripheral vision. So it could be one nerve, both nerves, could be the chiasm, which causes a problem with peripheral vision, which I'll show you in a moment. So how do we evaluate it? Of course, we check the visual acuity. We check color vision. So people often are, why are you checking my color vision? Aren't you born either with good color vision or bad? And the answer is about 7% of Caucasian men have a color deficiency. That doesn't mean they can't see color. If you say, what color is this? That's red. But they have trouble matching colors. And if they're colors like browns and blacks and so on, but 7%, so 7 out of 100 Caucasian men have a color deficiency that they're born with. But the optic nerve is very sensitive for color vision. So I call it our neuro-ophthalmologist's secret weapon, because if someone has decreased color vision in an eye, in one eye especially, it's acquired, it's new, and then that can happen if a tumor is pushing on the nerve. So color vision can be very helpful in both ways. If the person has pretty good vision, but bad color vision, I'm worried about something compressing the nerve. If they have poor vision and good color vision, it's probably not a tumor. It's probably not a nerve problem. So color vision is very helpful. Has anyone have their color vision tested? No, a lot of people haven't. I mean, hopefully you don't need to. And then peripheral vision. So there are different ways to check peripheral side vision. We call it visual fields. One way that you've probably had checked is the doctor sits across from you and uses themselves as a control, and they hold up their hands. How many fingers do you see? How many fingers do you see? No, don't look at my fingers. That's cheating. Keep looking at me, look right at my eye, and use your own eye as the control. How many fingers do you see? That's a very, very gross way to check visual fields. If someone can't see your fingers, they've got a big vision problem. So we have other ways to check vision. And this picture here is of a woman in what we call a visual field machine. This is the test where a little light flashes on the screen in front of you. And when you see the light, you have a beeper in your hand, you beep the beeper. How about that? Many people have done this. So this is a pretty routine kind of a test in a lot of offices. I mean, unfortunately, it's almost too routine just because people buy a machine and then they got to pay for it. So everyone gets a visual field test. We try to use it selectively when we think we need it, but it's a very sensitive test. And I tell patients, the good news about this test is very sensitive. It's designed really to try to pick up a problem before you even know it. And certainly I see people who have known pituitary tumors who say, yeah, my vision's fine, and yet we do the test and it's not fine. And they already know they have pituitary tumors. We also find it the other way around. We'll find problems on the test that clue us into, oh, there's a neurologic problem going on, you need an MRI. Oh, happens to be a pituitary tumor. So I tell people, the good news is it's very sensitive. The bad news is it's very sensitive, which means if you're having a bad day, the test might look crummy. And I spend some amount of my time interpreting or explaining visual fields when the doctor does it routinely just on everybody. Guess what? Once in a while, it's going to be abnormal. Oh, well, your eyes look fine. Oh, maybe you need to see a neuro-ophthalmologist. And the answer is repeat the test. And then you give them a little pep talk, explain how to actually do the test, and you cure them with the retake. So that's something that happens as well. So it's very sensitive, and if you're having a bad headache, don't even do it. Just you're going to get bad data, and that bad data can actually lead to unnecessary testing. So peripheral vision, optic nerve, peripheral vision is usually determined with if it's really an issue, if it's an important part of the evaluation. So anybody with a pituitary tumor, and I get tons of referrals of patients who already know there's a pituitary tumor, please evaluate, and of course get a visual field test. So we call it computerized testing, or computerized perimetry is the name of the device. And this is what the results look like. So I always show this to the patient and say, here's really, you just need to concentrate on this circle right here. We call this the gray scale because there are different shades of gray. Where you were asked throughout the test to look right straight ahead is where these lines intersect. This is to the right as you're looking out. This is to the left, up and down. This spot right here is your normal blind spot. So everybody, all of you, me, has a blind spot. In the right eye, it's on the right at about 15 degrees. And at the left eye, it's on the left at about 15 degrees. And that corresponds to the nerve in the back of the eye. And everybody has this blind spot. So that spot is normal. What we're looking for are other darkly shaded areas. And this is a pretty normal looking visual field test. It should be a little bit lighter in the center, should be a little bit darker around the edge. Well, there's a little darker spot up there, but within test taking, that's probably fine and not something to worry about. So that's what normal looks like. Here's another patient where it's not normal. And this person, as you can see, it's here's what we call the vertical midline. To the right, it's pretty normal, but to the left, it's not normal at all. And all that dark shading means is that compared to other people about your age who are normal, the computer had to turn the light up a lot brighter for you to see it in that area. So the brighter it had to turn the light up, the darker the shading is. If it's just a little bit shaded, like in here, it means the computer just turned the light up a little brighter than normal for your age. If it's really dark, like here, then it turned as bright as it could, and you couldn't see the light. And so this would be a typical pattern right down the middle. If there was chiasmal compression from the tumor, this is the left eye, so this would be the left eye right down the middle to the left. This would be what the left eye might look like in a patient with a pituitary tumor. Now, this person might not be able to count my fingers over here, but they might. This test, remember, is very sensitive. So sometimes I'll see people with a test result like this and say, oh my gosh. And they'll say, what? I said, you must have a lot of problems with your vision. Not really. And I check and they're counting my fingers. And yet the test comes out like this. So this tells us that the tumor's pushing on it, but not enough to cause a lot of symptoms yet. On the other hand, this test could look like this, and they might not even be able to count my fingers off to the side. So you always want to correlate the computerized test with your own testing and counting fingers. And then we're going to look at the optic nerve, because the optic nerve, the start of the optic nerve, is all we can see with our exam in the back of the eye. And this is a picture of a normal optic nerve. So this round circle right here is the nerve. These are blood vessels. So this is what we see when we look in the back of the eye. All around the optic nerve is retina that coats the back of the eye. The retina is like film in the camera. Light comes into your eye, stimulates your retina, generates a signal. That signal comes into the nerve. So there's a million little fibers that come from all the parts of the retina and in through this hole in the back of your eye to form the nerve, which then comes out the back of your eye. And the nerve should look nice and pink, like this nerve does. This is a very normal looking nerve. But sometimes we'll see nerves that look more pale or white. And this is a sign of permanent damage, which is what we don't want to see. Unfortunately, a lot of times, if you catch the pituitary tumors early enough, there isn't permanent damage, maybe case in point in the back of our room, but where the tumor's pushing on the system enough to cause to prevent transmission of the signal to the back of your brain, but not enough to permanently kill those fibers. But if the fibers are dead, then they don't regenerate. And in 2024, we don't have a way to regenerate them, although there's a lot of research being done on that. And there's been some progress made. When the fibers are gone, they're gone, which is why you want to fix the problem sooner than later when vision can recover. And thankfully, lots of times, the vision does recover very well, even to completely normal, when you relieve the pressure on the visual system by the tumor. And then there's something that's fairly new, and fairly new in neuro-ophthalmology. Fairly new means in the last like 15 years, but fairly new, called OCT. Has anyone ever heard of OCT? A couple. So ocular computerized tomography, which is really, it's pretty cool. To the patient, it seems like they're taking a picture. All you do is put your chin in the chin rest, look at a little target, and the person on the other side clicks a button. Oh, they're taking a picture with my eye. No, they're not. What they're doing is it's actually measuring the thickness of your nerve fibers. So it's actually measuring these million little fibers, and it knows what normal is. And then it can look at normal and look at your thickness, and it can actually tell us, not just, well, the nerve might be a little bit pale looking. It tells us how bad the damage is and if it's permanent or not. So this has been a big change in how we evaluate patients with tumors that might be pushing on their visual system. And just to make a fairly long story short, so this circle right here is the measurements of the thickness of the nerve fibers that form your optic nerve. And basically, when I show this to patients, green is good. Green means that compared to age-matched normals, your thickness is normal. Red, not good. So red means it's thinned. And when it's thin, this does not recover. So we have a better way to provide visual prognoses about vision. When they take that tumor out, is my vision going to get better? Well, your OCT looks great. So that means there's no permanent damage. So probably it will. Or your OCT shows some damage. So you still can improve some, but there's going to be some permanent changes. And the red here, the yellow is borderline, and the red is thin. So these days, pretty much anybody with a pituitary tumor is going to, of course, get their vision checked, their acuity checked. They're going to get, in my clinic, color vision. They're going to get a visual field. They're going to get an OCT, which is what this test is. Okay, so that's how we evaluate the visual system, or how we should evaluate the visual system in patients with pituitary tumors, or really any central nervous system problem with vision. So what about the vision problems that can occur? Well, so that goes back to the anatomy, right? So here's the same schematic that we've been looking at. Here's the optic chiasm. Here's an MRI with a cut right through the center of your head, right through the chiasm. Here's a chiasm right here, cut right in half. So this is cutting right like this, right?
And this is the sella, and here's the pituitary. So in this case, and here's the pituitary stalk, that little line right there. In this case, this is a more normal looking situation. And here it is, it's the same picture, but here's somebody with a pituitary tumor. Can't remember if this was an acromegaly, growth hormone producing tumor or not, but here, look at the chiasm. It's just stretched and draped out over the top of this tumor. That's obviously putting lots of pressure on it because it should be right about here. So in this case, the tumor is going straight up, affecting the optic chiasm where those fibers are crossing. And those fibers that are crossing come from the nasal, the inner part of the retina here. So they come back and then they cross over like this, and the same over here. These fibers come in and they cross over here. So if you have a tumor pushing right on the chiasm, it affects these fibers which see out to the side. So in the left eye to the left, and in the right eye, right here, to the right. So here's what the visual field test would look like. Loss of what we call the temporal versus the nasal part of the field of vision, right down the middle in both eyes. And that's what this person's field looked like with that pituitary tumor that I just showed you. So we call it a bitemporal hemianopsia. I'm not sure you need to know that, but loss in both temporal visual fields. And this is a computerized perimetry, right? Checking the visual fields. This is the left eye. This is the right eye. And you can see there's something about this vertical here. There's this almost all the dark shading is to the left over here. And almost all the dark shading really is to the right. It's not complete because the tumor isn't putting a lot of pressure on it. This person may have minimal symptoms, maybe even no symptoms, but they clearly have visual dysfunction because of the tumor and the pressure on the optic chiasm. If there are questions, please raise your hand. Okay. And so here's where the OCT can be helpful. Here's a patient, here's the MRI. So we have a cut, a coronal image, the same cut that we were looking at. You can hardly see where the chiasm is, but this is the tumor. So you can imagine somewhere the chiasm is there. And the patient really is asymptomatic. And the visual fields don't look bad. There's a little bit of shading. Remember, here's the normal blind spot, another normal blind spot, a little bit of shading over here, but look at the OCT. The OCT has thinning of the nerve fiber layer and tells us there's already been some permanent damage. Now, fortunately, the patient is asymptomatic. But here's a time when if I were to just look at these visual fields, I'd say, I don't know, it looks kind of nonspecific. But when I look at the OCT, I say, whoa, something's going on. And if we don't know what's going on yet, they need an MRI to look for something affecting the optic chiasm. So the OCT can show us, can even be more sensitive than the visual field testing. Question?
So what would that patient experience?
Yeah.
If you're...
So the question is for whoever might be online, what would this patient experience? So maybe absolutely nothing. And that's sort of the point. I mean, with this visual field, most people with these very mild, they may have no symptoms at all, none at all. So in this case, the patient, as I remember, was asymptomatic visually. And we didn't discover it, therefore, they were sent to me with, hey, they've got this is a pretty big pituitary tumor, their vision must be affected. And the patient's like, no, not really affected. And sure enough, it was somewhat. The good news is, although there is some permanent damage, you don't really need all those million fibers to have pretty good vision. You can lose probably 100,000 and maybe not even know it. But you want to relieve the pressure before you lose more of the fibers and you have the symptoms. And that's sort of the point. So this patient really wasn't experiencing much of anything. And that's why when patients, there's the endocrinologist, the neurosurgeon, and the neuro-ophthalmologist. So the patients all make their rounds. So if an endocrinologist diagnoses a pituitary problem because of hormones, they get to the neurosurgeon and the neuro-ophthalmologist. If there's a diagnosis by me, they get to the neurosurgeon and the endocrinologist, and the same with the neurosurgeon. Even if the patient tells them, my vision's fine. I had a young fellow recently in college, a college student, and he had a prolactin problem and impotence. And so they found his prolactin issue because of the impotence, and Ordered an MRI. Oh, he had a big tumor, not a growth hormone, but prolactin secreting tumor. And the endocrinologist said, oh, well, you got to go see Dr. Golnik. He's a neuro-ophthalmologist. And the kid said, well, my vision's fine. He said, well, just go see him. And we put him in the chair and covered his left eye, checked his vision 20/20. Oh, I can't see the chart. He was legally blind in his left eye. And that's part of the point is we got two eyes for a reason, because you can have a problem with one eye and maybe not even know it, especially if you don't do this. And here's a college student who knows he has a tumor that can affect his vision, who's telling him, no, I'm fine, but he never did this. So it's interesting how some people, the second something gets a little blurry, you're going to notice it right away. It's really very patient dependent as to the symptoms and severity. So yes, another question.
So if you don't know yet that there's a tumor,
Yes.
do the visual field test, etc. And how do you see difference between if it's nerve question versus the brain issue?
The question is, how do you know whether it's nerve or brain? If there's a tumor pushing. So we see different patterns on the visual field testing. So if it's nerve, any part of this visual field, because then you can be affecting any of those million fibers. If it's chiasm, then we're thinking it should be the fibers that serve the vision to the side. And so we would see this sort of a pattern. So this is a patient who I said, okay, this is probably the most common reason to have this pattern. Loss of vision to the temporal side in one eye, loss of vision to the temporal side is something affecting your chiasm. And the most common is pituitary tumor, by far, the most common thing. Now, I didn't really go over it, but since you asked, if, let's say the tumor's pushing, instead of pushing right here, because they don't always do what they're supposed to, patients don't always read the textbooks. Let's say it's pushing over here a little bit. If it's pushing over here, now what are you going to see? Well, now those fibers over here, after you go past the chiasm, the fibers that serve the vision in the left eye to the left, and the fibers that serve the vision in the right eye to the left. So then you would see right down the middle a problem to the left in both eyes. And then we'd say brain. Something's going on with the visual pathways in your brain, not the chiasm, not the nerves. Does that answer your question? Well,
And that's the visual path.
yes, the visual pathways, we call it retrochiasmal, behind the chiasm. Then you see a different pattern with the visual field test. You're all going to have a quiz at the end of this. I'm giving you my residence visual field lecture. But yeah, that's how you would know where to localize it. And that's what I thought was so cool about neuro-ophthalmology when I was in medical school. It's like you could go into the room with very little equipment and know exactly where that problem was. You wouldn't know if it was a tumor or a stroke or MS, but you know there's something right in a specific place. When I thought that was cool. Yes.
Question, I had my tumor removed in 2008, and then last year they said that they didn't get all of it out, and that the reason was because it could have damaged the optic nerve. But when I look at a picture of the pituitary, it kind of looks like a pear shape,
Mm-hmm.
and I think my tumor was on the side, so they said they like scooped it out.
Yeah.
So in the pictures, it seems like the optic nerves is on the top of it. So how would they?
Right. So certainly when there's a tumor causing a vision problem or compressing the nerves, the number one thing you don't want to do is hurt the nerves, which is why most of the surgeries are done through your nose, because the vision system's up here. So it's safer because you can go up here, hopefully pull the tumor down. But sometimes the tumors are sticky. Sometimes they're even wrapped around the nerve, and they say, gee, it probably won't hurt to leave that little bit. But if I try to dissect that little bit of tumor off the nerve, I mean, I definitely see people on occasion who wake up with loss of vision from the surgery. And so do no harm is the first thing. If there's a little tumor left over, usually with the benign tumors, it's not a big deal. Of course, that's why they will follow you with MRIs to make sure nothing's changing over time. But yeah, I mean, it's not uncommon that they'll debulk, which means not remove all of it, get as much as they can, being very safe, avoiding the nerves and the chiasm, because that's exactly what they're trying to prevent. But once in a while, I mean, I do see people who
have post-operative surprises with their vision, yeah.
Can I say that happened to me?
Ah,
So, I'm already blind in my left eye.
Ah.
Usually, yeah.
oh gee,
And, so I got, the Acromegaly diagnosed in 2007.
Huh.
Post, surgery, about 2 days after surgery, I started to notice a weird pixelation of my vision on the right-hand side.
oh,
And the field test data showed that I pretty much lost
wow.
half of my peripheral vision.
That was after the pituitary tumor surgery.
I
Huh,
actually could see the vision go.
wow.
That makes
But it wasn't like upon awakening from the surgery. What did they do? Did they, what?
They didn't do it.
And did they repeat the MRI or anything? Or-
What they would have done.
Yeah,
I think it was just,
yeah.
but when I'm already blind in one eye.
Well, right. I mean, that's, as I always tell people with one bad eye, that's why you got two eyes. But if you have two bad eyes, then that's another story. So,
Your brain
hmm.
not seeing.
Huh. It's odd to me that it would happen not right away, because usually something bad happened to the blood supply or the manipulation of the nerve, and it's, you wake up and the patient says, uh-oh, I can't see out of this eye. Having it delayed bothers me a little bit, because sometimes they use, there can be over aggressive fat packing. So when they go up there, they put some fat up there. And I mean, I've seen patients who have deteriorating vision, and then you repeat the MRI and you see all this fat, and like, go back, get rid of some of that fat, and they have to take you back to the operating room.
Well,
Mm.
yeah.
Uh,
But I don't know.
yeah,
It is what it is.
yeah, yeah, oh yeah, yeah, it can't. Well, that's like a double, that's lightning striking twice, an AVM and a pituitary. Some people are just lucky. Yeah, wow. All right. Another question, yes?
Yes, surgery, well, my tumor was pushing up on the optic chiasm, but luckily it was lifting it, and it wasn't necessarily
Right,
compressing it. So anyway, before surgery, they did the visual field and didn't see anything.
good.
But I have, and I don't know if this has to do with anything, I have persistent flashes of light every day, every night. I've already had complete, vitreous detachments
Oh,
that are complete, so.
so you shouldn't have flashing.
Flashes of light,
Yeah.
anything to do with nerve?
Certainly, I mean, I certainly see people who have had compression of the optic nerves or the visual system where they have flashing lights. They see flashing lights and in the recovery phase. And I say, gee, maybe it's because those fibers are trying to recover. Usually they gradually get better over time, but I'm assuming you had your surgery a long time ago.
Yeah, I had it April 2021, the first surgery, the second surgery, March of 2023.
Oh, well, that's,
Both eyes, persistent flashes
Huh.
every day,
Huh.
and I see them at night
Yeah.
mostly, but it's always there.
and it's not getting better or worse, it's just kind of the same. I mean, I think the answer is the visual system can do some funny things and produce some funny hallucinations, because I mean, really, that's what that is, an hallucination. It's a light that isn't there that you're seeing. I don't know, if you were to see me with that complaint and hadn't had an MRI, I'd say, well, let's just check the MRI, make sure nothing's going on. See, right now, they don't think there's any tumor pressing on your visual system. Is that true?
Yeah, they think they got all the tumors.
They do, okay. Yeah, that's probably all I would do otherwise, other than a complete eye exam, because as you mentioned, the more common cause of flashing lights would be the vitreous gel in the eye itself. But if that's already, that gel can pull and cause flashing lights, but if it's already detached, which is a normal process, then the flashing light should theoretically go away. And your eye doctor said that the vitreous seems to be already detached.
Yeah, the left eye, that flash has been going on since September of 2021. As you never.
I doubt it's anything to worry about, but I don't know how to tell you to fix it. Yeah. All right, I think I've just got, we did that. Oh, so just one last thing to say about the double vision. Remember when we talked about the anatomy, and again, here we are, the pituitary, here's the chiasm, but on each side of the pituitary gland, so this is looking at the patient, are what's called the cavernous sinus. So there's a sinus here and here.
Actually, this sinus is not filled with air, it's filled with blood, but these nerves run along and in the cavernous sinus. So if the tumor were to go this way instead of this way, it would affect the nerves in that area, which are nerves that go to the muscles that control your eye movements and your eyelid. So here's a gentleman who, I'm going to play the video, or I'm going to try. There we go. And you can see his left eyelid's completely closed. We're going to look at his right eye, which is normal in terms of its movements. I always tell my students, don't ignore the eye you think is normal. It might be a little bit abnormal, but look at it. And his right eye is normal. Now we're going to open his lid. And you'll see that his eye moves out okay, but look at it, doesn't move up or down or in. So he has a problem actually with a couple of these nerves. So everyone has 6 muscles that move the eye up and down and around, plus of course muscles in the eyelid that keep your lid open. And he has a problem with a couple of the nerves because the tumor had grown to the left and was compressing those nerves. And so he initially had double vision because with his eye open, his eyes are not lined up straight. So in this kind of double vision, one eye sees this and one eye sees this. You can close either eye and get rid of the double vision. Even the eye, I mean, even we can close his right eye and open his left eye with our hand and he'll still have single vision. So it has to do with the eyes not working together. There's misalignment and even a little bit. So this is a pretty complete situation. And this is actually after surgery because they had to go and muck around and they stretched the nerves and they tried to remove the tumor. Fortunately, this did gradually improve. So here he has no double vision because his lid's shut. So when his lid, the first thing I tell patients is usually the first thing that happens is your lid starts to open up. And then guess what? You're going to have double vision and you're going to have to do this. So sure enough, he came back for a 6-week check and said, yeah, now I got to do this because my lid's starting to open and now I've got double vision. I said, well, good. It's good news. That means the nerves are starting to recover and your eyelid's opening up. So double vision, not nearly as common as loss of vision, but double vision is something that I see tons of patients with double vision for all sorts of reasons. And sometimes it's due to pituitary tumors pressing on either side. I had one patient who had complete loss of eye movements in both eyes because the tumor went like this, both directions. Both lids were shut and neither eye moved at all. And it all completely recovered after surgery. So in summary, the pituitary tumors can affect the vision in a variety of ways. Sometimes it's very obvious, but sometimes the patients are asymptomatic, which is why you might be sent, if you have a tumor, to me, even though you're protesting, my vision is fine, I do not need to see him. Sometimes we will find things that are subtle with some of these sensitive tests that I described. And neuro-ophthalmic evaluation at least can certainly identify some of these subtle sort of things and abnormalities with the testing that we have in 2024. So I think we have maybe a few more minutes. No, I guess we have to end in 5 minutes, but we had a bunch of questions. Anyone have any visual experience? Or go ahead.
I've had some like vertical diplopia,
in
both eyes, like
Okay.
separately. Like,
Okay, so I see patients all the time sent to me with double vision. And I always start by telling the patient there's 2 kinds of double vision. Monocular, which means you can do this and it's still double, or this and it's still double. It could be one eye or both eyes. And binocular double vision. So the patient we just saw, the reason you have binocular double vision is your eyes are out of balance. So in binocular double vision, 100% of the time, it has to go away when you cover either eye. Because the only reason you're seeing 2 is because this eye sees one and this eye sees one. If the patient says, oh no, it's my right eye, when I do this, it's still double, I say, you do not have a neurologic problem. And I try not to see those patients because that is almost always due to the way light's focused by the front of the eye. And so I don't do front of the eye stuff. My parents wanted to know which eye I was going to specialize in. And so that is a whole different story. Glasses, dry eye, cataracts, corneal, whatever. But that is always related to the way light's focused. So I have a little astigmatism. I don't like to wear glasses. But if I look at an exit sign, I get a little bit of that vertical thing there. And it's in one eye. And if I squint, sometimes it helps. But that's a trivial, not a neurologic problem. It's always to do with the way light's being focused by the eye. Yes. So as far as, I looked because I figured someone's gonna ask me that. Uh, I don't think so. I couldn't find anything, that was unrelated to actually pressure. And that's why it's, the good news is that doctors are so used to, if they find a pituitary tumor, to send it to, or an eye exam. But if the tumors on the MRI is not touching the visual system, it can't be causing an eye problem. So I don't want to dissuade doctors from sending patients to me just if they have pituitary problems, but if their MRI doesn't show any pressure, I usually tell them it can't be causing a vision problem. So the answer, I don't believe so with growth hormone and eyes, not something I've heard of. I mean, yes, yes.
The not hormone, after my first surgery, right after, I had blurred vision.
Oh.
And I had very good vision before surgery.
Hmm.
And since that surgery, I need glasses to be able to read. And afterwards, before they didn't send me to neuro-ophthalmologist, but afterwards they sent me to neuro-ophthalmologist. But, and there was, the tumor was not close to the optic eye or anything. But I had DI. And I asked, is it possible that because of the electrolyte imbalance in sodium, I also had SIADH dictator because of the fluids and everything that could affect the eye, which is not a nerve or a neuro.
Right, compression, yeah. So do you mind me asking how old you were when you had the surgery?
41.
41, okay. So, as probably a lot of you know, I won't say who, as we get more mature, it's natural that we lose our reading vision ability unless we're nearsighted and take our glasses off. But with your glasses on, even those nearsighted people are gonna need reading glasses. Certainly that usually starts happening in the 40s, sometimes a little later, sometimes a little earlier. And I definitely see people with all sorts of different like head injuries who I'm 42 and I didn't need reading, now I need reading glasses. So I think there are things like brain surgery that can be the straw that breaks the camel's back into needing reading glasses. I assume you permanently needed the reading glasses. It wasn't a transient thing. So when the SAADH went away, you didn't regain your reading. Yeah, I mean, it has to have, the reason that we can focus up close as young adults is that there are muscles in our eye that change the shape of our lens. And as we get more mature, the lens gets more and more rigid, and eventually your arms are too short and you have to have reading glasses to help pull that focusing in because you can no longer change the shape of that lens and ultimately it becomes a cataract and you have it removed. So I don't know. I mean, I personally haven't had that happen, but I've had people with other sorts of neurologic issues in their 40s who said, well, before this started, I could read, now I can't. And so I don't know the answer for sure, but it's certainly possible. It was gonna happen. It's possible it happened a little earlier because of the whole just shock to the system. And maybe the hormonal and the electrolyte changes, straw that broke the camel's back kind of thing. Yes, one last question, I think. So all right, well, maybe two, because I think something else is going on in this room or I'm not, yeah, okay. Okay, in the back first and then you, Ben. Presuming you had a normal pre-surgery exam or no? Certainly anybody who has an abnormal pre-surgery exam, we always see them back to say, look at how great you're doing. Hopefully you're doing so well, you're improving. We show them the visual fields, side by side and so on. If I see someone before the surgery with a normal exam and the tests that we did were normal, I usually don't set up a routine follow-up afterwards. Unless, of course, there's symptoms, but I don't usually set up a routine exam. Yes, ma'am.
So if in general, very much in general, someone is told that a remnant of a pituitary tumor was left in there because it was, quote, too close to the optic nerve.
Right.
And the patient has to be on medication to control either hormone IGF, but has no additional vision issues. It sounds to me like it's wisest to just let the tumor be in there until some other thing comes up that seems like they really have to go back in and try to get out as much as it can and
Right.
possibly interfering with vision permanently.
Right. I mean, I think the problem is the nerve is, you know, on the pictures, it looks pretty big and sturdy, but it's not. And so it's everything in medicine is a scale. You know, you got the pros and the cons of doing this or not doing this. Well, we could go dissect a little closer to that nerve, get a little more of the tumor. I mean, the bottom line is it's way more common to have a little tumor left than not to have any left. And even in people who said, you don't have any left, why do I need an MRI then every year? So it's unusual, I think, that the tumor will be completely gone. And a lot of times, you know, you repeat the MRIs, repeat them, nothing changes, nothing changes, nothing changes. Now, in the setting of a secreting tumor, which most aren't, but in acromegaly, then it does kind of suck that you'd have to take hormone, you know, take medicines because of that little residual tumor left. But again, well, or I'm worried you might be blind in that eye or in both eyes. So we're going to do the medicine and not take that risk. And that's, you know, that's kind of a neurosurgeon's, well, job.
Yeah.
Yeah.
Okay, thank you.
Well, one more question.
So in the case where a patient has had a tumor removed, two surgeries within a short period of time, and there's residual left, the follow-up was the second surgery was to actually remove enough tumor so gamma knife could be administered. So after that, it doesn't seem any unusual vision changes or anything. Is there any prescribed ophthalmologic follow-up?
Yeah. So usually what I do, if there's residual tumor and it's either really close or touching the visual system on the MRI, I see the patient as long as they're asymptomatic, I see them as often as they're getting follow-up MRI. So if the neurosurgeon is recommending a 6-month MRI, I get a 6-month exam, but I stagger it by 3 months. So really, every 3 months, they're getting a check, either an MRI, then 3 months later, a visual field and an exam, 3 months later, an MRI. If they then say, okay, nothing's changing now, we're gonna go to a yearly MRI, I say, okay, we're gonna do a yearly exam, but we're gonna stagger it by 6 months. So 6 months, we'll see you, 6 months later, MRI, 6 months later, eye exam, 6 months later, MRI. And that's usually what I do.
There's no interference with the your eye actually.
Yeah.
There hasn't been any issue. Then is it still?
I still do unless they say, well, yeah, there's a little residual tumor and it's, 5 millimeters away from the visual system. Then I say, now, if your MRI changes, we'll see you. But like I said earlier, if it's not touching your system, it can't affect your vision. So that would be the recommendation. And then I just tell the neurosurgeon, hey, if you're repeating MRIs, if it gets near the vision system, send them back. If it's already, the residual is right there, then that's when we see them regularly, like the MRIs.